Assalomu alaykum, hurmatli hamkasblar, hurmatli mehmonlar. Assalomu alaykum. Bizani vatandoshlardan tashqari bu yerda bir guruh, katta guruh qo'shni davlatlardan kelgan mehmonlarimiz ozgina bizani tashkiliy masalalar bo'lganligi uchun kechroq boshlayapmiz, uzr so'raymiz. O'shaning uchun ruxsatinglar bilan men sizlarni tanishtirsam, shu yerdagi prezidiumdagi a'zolar bilan bizni hurmatli vazirimiz Xudoyorov Asilbek Anvarovich keldilar. Rahmat, katta rahmat. Xitoy Xalq Respublikasini bu yerda O'zbekistondagi elchi janoblari shu yerda o'tiribdilar va yonimda, chap qo'limda Birlashgan Millatlar Tashkiloti vakili, albatta shularning loyihasi orqali bizga O'zbekistonga Xitoy mutaxassislari bilan kirib kelayotgan yangi texnologiya bo'yicha bugungi simpozium госпожа Ning va professor Pan chetda o'tiribdilar. Bular shu texnologiyani tatbiq qilganlar Xitoy mutaxassislari bilan birga va albatta o'zlarini tajribalari bilan bizlar bilan bo'lishga kelganlar. Men mamnuniyatdan so'zni bizni hurmatli vazirimiz Asilbek Anvarovichga beraman. Marhamat Asilbek Anvarovich.
Assalomu alaykum, hurmatli mehmonlar, hurmatli xonimlar va janoblar. Bizni uzr so'raymiz, ozroq belgilangan vaqtdan kech boshlayapmiz. Ruxsat bersalaring, rus tilida davom ettiramiz. Уважаемая госпожа,
Dear Ms. Ninin Yang, Your Excellency Mr. Ambassador Yu Jun, dear Dr. Sanbin Pan, dear colleagues, ladies and gentlemen. Huayin, welcome to Tashkent. On behalf of Ministry of Health and from me, I would like to welcome you to our sunny, hospitable city of Tashkent, a city where tradition of East meets achievements of medical science, and for us it's a great honor to host this regional symposium on percutaneous and non-fluoroscopic interventions organized together with the Department on Economic and Social Matters of United Nations and our partners from China. Uzbekistan has been steadily moving towards healthcare reforms, and thanks to political will of our president, Mr. Shavkat Mirziyoyev, we are implementing comprehensive strategy aimed to improve the accessibility, quality and sustainability of medical assistance. We established new clinics, we have innovative methods, we expand international partnership. In this context, the methods as a part of our symposium will not just help our patients, they will have a training component. And now I would like to say that this high-tech, non-fluoroscopic, non-invasive or little invasive approach is especially valuable in the surgery without X-ray. It's very humane to humans, especially children. Today's symposium is not just exchange of knowledge. It would be the starting point to expand regional cooperation, technological transfer, training of new generation of doctors who would be able to apply this procedure, their experience. We are sincerely grateful to our foreign partners from China, Turkey, Russia, Kazakhstan and other countries for their input into knowledge and common approach. I'm sure that this presentation and our discussion would be a firm foundation to develop these methods in our region. I wish all the participants inspiration, new ideas for their productive work, and wish everybody personally good success, and most importantly, let the result of this symposium would serve the goal to save thousands of children's lives. Wish you successful work, and let all your dreams come true. Thank you very much for your attention. I've tried to speak some Chinese.
Marhamat.
Thank you, Professor Ismailov. Thank you. Your Excellency, Professor Hodiarov Asubak, Minister of Health, Republic of Uzbekistan. Your Excellency, Ambassador Yu Jun, Ambassador Extraordinary and Plenipotentiary of the People's Republic of China to the Republic of Uzbekistan. Professor Sadimarov Ismailov, Director, Republican Specialized Scientific Practical Medical Center of Surgery, Republic of Uzbekistan. Dr. Pan Xiangbing, developer of the Percutaneous and Non-Fluoroscopic procedures, Fuwai Hospital of Chinese Academy of Medical Science, and Chief Technical Advisor of Pump Procedure Project under the United Nations Peace and Development Trust Fund. Distinguished experts and guests, professors, doctors, ladies and gentlemen, good morning. It is a great honor to be with you today on behalf of the Capacity Development Program Management Office of the United Nations Department of Economic and Social Affairs, UNDISA. I bring warmest greetings from our Undersecretary General, Mr. Li Junhua, and our Head of Office, Mr. Lu Haitian, along with our deep appreciation for your partnership. Let me begin by expressing our sincere gratitude to His Excellency Minister Hodiarov and to the Ministry of Health of Uzbekistan for their generous support. I also wish to thank Professor Ismailov and his colleagues at the Republican Specialized Scientific Practical Medical Center of Surgery for their exemplary hospitality and partnership. Today's gathering would not have been possible without your leadership, dedication, and unwavering commitment. We are also deeply honored by the presence of His Excellency Ambassador Yu Jun. I would like to take this opportunity to sincerely thank the government of China for its generous contribution to the United Nations Peace and Development Trust Fund, UNPDF. Since its establishment in 2016, the UNPDF has played an important role in supporting the United Nations work to promote peace and development, including advancing the implementation of the 2030 Agenda for Sustainable Development. We are especially grateful for the active participation of leading cardiovascular experts from Uzbekistan, China, Kazakhstan, Turkmenistan, Kyrgyzstan, Tajikistan, the Russian Federation, and Albania, who bring both expertise and vision to this initiative. Your presence here today reflects our shared commitment to advance equitable and innovative solutions in cardiovascular healthcare. Health for all is a central aspiration of the United Nations, enshrined in the Constitution of the World Health Organization and the Universal Declaration of Human Rights, and recently reaffirmed by 193 member states of United Nations in the Pact for the Future. It's a cornerstone of the 2030 Agenda and a critical enabler for achieving nearly all Sustainable Development Goals. Simply put, essence, health is the foundation of social and economic progress. Today's event takes place 1.5 years after the approval of the UNPDF project on pump procedure endorsed by the United Nations Secretary General in November 2023. It also marks the project's first regional activity in Central Asia, following the successful International Scientific Symposium in Turkey last year. The project seeks to enhance treatment capacity for structural heart disease in selected developing countries by promoting the adoption of pump procedure, supported by comprehensive community screening and professional training initiatives. At its core, this project embodies our shared ambition to expand access to life-saving cardiovascular care through innovation, inclusion, and commitment. It seeks to ensure that no one is left behind, especially children, women, and those living in poverty. In doing so, the project contributes directly to accelerating progress toward the Sustainable Development Goals, particularly Goal 3, ensure healthy lives and promote well-being for all at all ages. Ladies and gentlemen, today we stand at a pivotal moment in our global health efforts, particularly in the fight against cardiovascular disease, which claims millions of lives every year. The staggering statistics remind us of the urgent need for action. Worldwide, nearly 18 million people suffer from cardiovascular disease each year, with structural heart disease accounting for a significant proportion. Sadly, only 1 in 5 people with SHD receive the treatment they need, highlighting the disparities and challenges in access to healthcare. Traditional treatment, while effective, has significant drawbacks, including high costs, invasive procedures, and risks to patient health. Our project introduces an innovative approach through pump procedure, which are guided by ultrasound instead of X-ray. This innovative technique not only reduces medical costs by over 40%, but also expands treatment options for patients who are previously unable to undergo traditional interventions. By expanding access to healthcare, reducing disparities, and promoting safer and more affordable treatment options, the project is well positioned to make a meaningful contribution to global health agenda. I extend my heartfelt congratulations to all those involved in today's scientific symposium. It is my hope that you will leave this event inspired with new knowledge, new tools, and renewed motivation to bring the pump procedure to those who need it most. I encourage you to apply these innovative and cost-effective methods to drive meaningful changes in patient care. I'm confident that today's gathering here in the beautiful city of Tashkent will be the beginning of productive connections, shared knowledge, and lasting impact. Thank you.
Keyingi so'zni mamnuniyatdan man janob Yu Zinga beraman, Xitoy Xalq Respublikasining O'zbekistondagi favqulodda va muxtor elchisi.
Уважаемый министр Худая,
Dear Minister Khudayarov, Director of Center Mr. Ismailov, Dr. Ban Sanbin, Ms. Yaninin. Hello, I'm very happy to be present at today's event. On behalf of Embassy of China in Uzbekistan, I would like to congratulate you with successful hosting of the seminar and thank all the medical experts, representatives of the ministry, and officials from United Nations offices for the efforts and support in preparing to this event. And of course, visit Dr. Professor Pan and his team to Uzbekistan. Health is a general wish of all humanity. One of the main threats for health today are cardiovascular diseases. From this disease, over 10 million people die, and medical experts across the world are making their best efforts to research and treat that. And one of the leading medical offices in China, Fuwai Hospital, for many years has been doing research in this field and has achieved substantial results. The developed methods of treatment were acknowledged in the framework of UN Sustainable Development Goals and are spreading across the world. By helping fighting with the cardiovascular diseases in many countries. History proves about many historical connections in medicine between China and Uzbekistan. In mid-ages, many works of Abu Ali ibn Sina were translated into Chinese language, which was a vivid example of exchanging experience in this field. In our times, cooperation in medicine between China and Uzbekistan is actively developing. For example, in recent years, a Chinese medical group within the framework of a program called Express Health has conducted 1,200 free surgeries to remove cataract in Uzbekistan and successfully restored sight in local patients. In Tashkent, opened and successfully working Chinese-Uzbekistan Technological Park, and also Hospital Fuwai has established firm connections with Uzbekistan medical facilities, and medical experts from this hospital has visited Uzbekistan to conduct surgeries on heart and exchange of experience in diagnostics and treatment. They are also inviting specialists from Uzbekistan to improve their quality. I'm sure that application and spread of innovative surgical methods in Fuwai would bring substantial help to patients with cardiac diseases in Uzbekistan, would improve the conditions of nation and will help achieving Sustainable Development Goals of United Nations. Dear guests, under strategic leadership of our leaders of our two countries, relations between China and Uzbekistan have reached historic level. Comprehensive strategic partnership in the new era. Cooperation and exchange in the area of healthcare takes an important place in deepening of practical cooperation between us. Dear President, Mr. Shavkat Mirziyoyev is dedicating big attention to reforms in this field, looking at improving systems of public health care as important task of Uzbekistan's strategy until 2030. China is also setting as a priority to provide public health, promoting the concept of healthy China. We are ready to deepen our cooperation with Uzbekistan in the field of medicine and healthcare, supporting medical offices and facilities in our countries in expanding exchange of experience and methods of diagnostics and treatment, and also conducting joint academic scientific research and training of staff, trying to establish healthy Silk Road and making input into improving the healthcare of our countries. I remember during the pandemics, our countries were helping each other. When we started the pandemic from Uzbekistan, very quickly they were sending masks and equipment, and then when we have established the good procedures and the situation was improved, we were also helping our Uzbekistan colleagues with medicines and vaccines. At the end, I would like to once again thank everybody for your attention in supporting medical cooperation between China and Uzbekistan and wish successful carrying out of the seminar. Katar Ahmad, thank you very much. Thank you.
Xitoy tibbiyot fanlari akademiyasining Fuvaykli kasalxonasi Birlashgan Millatlar Tashkiloti Tinchlik va taraqqiyot ishonch fondi pan loyihasi bo'yicha bosh texnik maslahatchisi.
Ladies and gentlemen, good morning. It's a great pleasure to visit Uzbekistan again. Actually, the Chinese medical team have visited Uzbekistan so many times. I still remember 7 years ago, I have a special case. It's a pregnant woman. So because she have a baby, so we cannot perform the open heart surgery or the fluoroscopy procedure for her because of the baby. So we use the PAM procedure. We use only echo to guide the whole procedure. We saved not only the mother, but also save the baby. 1 month later, the mother delivered a healthy boy, and we report the story in a very huge congress organized by President Xi Jinping. And the chief of the WHO gave a special comment about the story. He told us that we still have so many people live in the developing countries, live in the rural area. Even if we have the open heart surgery, we have the fluoroscopic guide procedure. But most of the people, they live in the village. They didn't have enough medical resource. So we need to help them. We need to save more lives in the rural area because they didn't have the open heart surgery. They didn't have the cath lab. It's too expensive. They cannot use this. not only in Uzbekistan, but also in Africa and most of the developing country. So that's the reason why we want to develop it, the percutaneous and no fluoroscopy procedure. That's the reason why we want to use only echo to guide the whole procedure. If we can use only echo, as we all know, echo machine is very cheap. It's portable. It's like a laptop. We can bring the echo machine to the village to perform the procedure. Many years ago in Africa, we performed the procedure under the tree. Even if we didn't have the house, under the tree, with the echo machine, we performed the percutaneous procedure to save the patients. And now we have a car, we have a vehicle. So you can drive the car to the village and go along one village and next village, go along and screen the patient and perform the procedure in the car. So that's the one-stop service. We can save more patients in the rural area and reach the same budget. I think it's very important why United Nations give us the financial and diplomatic support to help us to promote PAM procedure around the world. So we can increase accessibility, and we also can protect the patient. As we all know, fluoroscopy have a damage to the body. We call it iatrogenic damage. Just like some patients suffering from cancer, pregnant women, renal failure, even if the patient they are preparing to have baby, they cannot receive the fluoroscopy. So echo guide procedure can protect our patients, but also can protect the medical staff. In the PAM procedure, we didn't need a cath lab. We also didn't need a heavy protect shoe. Protect ourselves. We can work in a comfortable environments, so we can provide better service for our patients. So I hope that more and more doctors can join us, can use the PAM procedure to save more patients, not only in Uzbekistan. You are also welcome to join the international team. We will go around the world to save more lives all over the world. Thanks for your help. Thank you.
Bir og'iz tarjima qilib sizlarga tushuntirishim kerak. Agar ruxsat bersangiz, Asilbek Anvarich, professor Pan Sanbin hozir ikkita katta masalani sizlarga aytib berdilar. 7 yil avval homilador ayol, o'zbekcha ayolni yuragida homila paytda shunaqa parok aniqlangan. Shu aniqlangan tug'ma yurak nuqsonini homilador ayolga nima qilishni o'ylab Xitoy mutaxassislariga biznikilar murojaat qilgan va o'sha ayolni 7 yil oldin shu texnologiya bilan davolangan. O'sha ayol o'g'il tuqqan, soppaso. Bu professor Pan Sanbin gapiryaptilar. Shu ayolni topdik. Bu yerga olib kelamiz. Bolasi bilan shu ayol keladi bugun bizni markazga deb hozir gapirdilar. Ikkinchisi keyingi gal kelishlariga mana Farg'ona viloyatlarida viloyatida biz 2 kun ishladik. Bular bilan 4 mingdan ortiq bolalarini skriningdan o'tkazdik tug'ma yurak nuqsoniga. O'sha bolalarni endi joyida shu texnologiya bilan exa kontrol yordamida okkluderlar o'rnatish texnologiyasini katta mashina olib kelishadi. Bizga markazga podarka qilishadi va shu mashina bilan biz boshqa regionlarda ham o'zimizni mutaxassislarimiz bilan yurishni boshlaymiz. Bu ikkinchisi va uchinchisi albatta mutaxassislarimizga, Xitoy mutaxassislarimizga katta rahmat. Chunki bizani xodimlar o'sha 1 yil borib o'qib kelganlar bor. Keyingi seriyaga ham mana 1 yilga ketishga tayyor mutaxassislarimiz bor. Xitoy Xalq Respublikasiga, ularning mutaxassislariga katta rahmat. O'ylaymanki, shu Aslbek Anvarovich boshchiliklarida Sog'liqni saqlash vazirligi bir tarafdan, Birlashgan Millatlar Tashkiloti ikkinchi tarafdan ikkalaligi shu loyihaga 1 yildan beri gapirib kelayotgan loyihamizga mana bugun ikkalaligi start berishdi. Men o'ylaymanki, Sog'liqni saqlash vazirligining loyihasini biz albatta qo'llab-quvvatlab, bu yog'iga har bitta hududda o'zimiz ishlab ketish niyatidamiz. Katta rahmat. Ruxsat bersangiz, Aslbek Anvarovich, endi plenarniy dokladlarga o'tsak, professor Sanbin Panga so'z beramiz, ular moderator bo'ladilar.
Now we are going to start our plenary session, and the first speaker is Dr. Pan. He is going to talk about introduction to the PAN procedure and its role in advancing healthcare access.
Ladies and gentlemen, it's a great pleasure to give the presentation about the PAM procedure, the percutaneous and non-fluoroscopy procedure. So as we all know, the traditional treatment for cardiovascular disease is the open, it's the open heart surgery and the fluoroscopy guide procedure. So the fluoroscopy have iatrogenic damage. So the radiation can cause cancer and have damage to the body, and it's also dangerous for medical staff. And so many patients cannot receive the fluoroscopy guide procedure, and the castellat is very, very expensive. So even if in the United States, there are only 1,600 hospitals have castellat. In China, the number is 1,400. So it meant that we didn't have enough medical resource to save more patients, especially in the developing country. Another problem is that the fluoroscopy project a 3D heart to one 2D plate, only have one plate. We cannot find where is the valve, where is the chordae, where is the septum. And there is also no real-time modulating. So if we can use echo to take the place of fluoroscopy, we can have many advantage. So echo is radiation-free and provide 3D image and can provide real-time monitor. But it's difficult. All over the world, there are many experts that want to use echo to guide the percutaneous procedure for cardiovascular disease. But it's very, very difficult. Why? Because heart is totally different from a renal or liver, because heart is always beating. So when we insert a wire or catheter, the device will move with the heart beating. So it's not easy. It's very difficult for echo to find the device and to locate it or to find the orientation of the device. So it's very difficult to use echo to guide the percutaneous procedure. So what should we do can help more doctors to perform this procedure? We invent some novel device, just like the panel wire. The panel wire have a spindle shape. So it means that the top of the wire is bigger. It's easy for echo to find the top of the wire. So we enhance the ultrasound visualization of the medical device. So in a randomized trial, the panel wire can increase the success rate for the junior doctor from 69% to 100%. So it means that it's very easy for the junior doctor to learn and use the PAM procedure. So not only the device, we also have some special method to help you to perform the procedure. Just now I have mentioned the heart is beating, but the vessel didn't beating. So we can use echo to show the connect part of the vessel and the heart, just like the orifice of the IVC or SVC or the aortic artery. So echo wait here, wait for the wire or for the catheter. And we also have the working length. We measure the working length. We measure from the Percutaneous side to the right side, the third intercostal. Here is the project palm of the right atrium. So we know how deep we should insert the catheter. So at the beginning, we insert the short wire, short catheter, even if the panel wire, to measure how deep we should insert the catheter when we reach the defect. And then, according to the working length, we insert the stiff delivery system. Because the delivery system is very, very sharp, it's dangerous to make damage to the heart. So with the help of working length, it will be easy for us to prevent the complication. And we also have the effective play. So in the panel wire, we have top highlight, two highlight. One is on the top, another one is on the bottom. So when echo play can find the two highlight at the same play, it means that this play is the direction of the panel wire. So we can know the orientation of the device. So with the help of the new device and new methods, now we can use echo to guide all kinds of procedures safely. So if we can use the echo to save our patient, it will be safe. So we can protect not only the patient, but also the medical staff. You can find many old patients, the patient with cancer, the patient, even if the patient with the renal have a renal failure, the patient can use echo guide procedure to save them life. And we also can bring the echo machine. You can find the echo machine is portable, but the cath lab cannot move. So we can bring the echo machine to the village. Even if we didn't have the car, no problem. We bring the echo machine to the village, screen the patient, and perform the procedure in the local clinic. Only a room, only a bag. We can save the patient. And now, we can perform the procedure for not only congenital heart disease. At the beginning, we used the procedure for ASD, only ASD, and then for VSD, PDA, PFO, and then we try to use the procedure for heart valve disease, including mitral valve stenosis, aortic valve stenosis, just like the rheumatic heart disease. Even if for the tricuspid valve regurgitation, mitral valve regurgitation, now we can use a PAM procedure to implant pacemaker or perform ablation for atrial fibrillation. We also can use this procedure to implant stent. So I hope that you remember we can use PAM procedure not only for congenital heart disease, but for all kinds of cardiovascular disease. We can save so many patients. So with the help of United Nations and different governments, we have tried this procedure in more than 60 countries all over the world. Not only the developing country, including many countries in Africa, but also the developing countries. Every year, we bring the team to UK, France, Germany, Canada, Italy, Japan to perform the procedure. So in the developed country, they have enough cath lab. Why they need PAM procedure? The reason is that they want to have a high medical quality because they have more older patients. They have more patients suffering from heart failure, renal failure, suffering from cancer. So they want to save these severe patients. So with the help of PAM procedure, we also have the new device, not only the guiding device, but also the treatment device, just like the absorbable occluder. As we all know, the mental occluder have all kind of problem, long-term complication. So we want to develop the absorbable occluder. But the problem is that fluoroscopy cannot find the absorbable material, so we cannot implant the occluder. So we have to add several marker on the occluder. So when the occluder is absorbed, the marker go away, the patient will have brain infarction. So with the help of only echo, we can implant the completely absorbable occluder. So now we have the absorbable occluder, not only for VSD, for ASD, for PFO. We also have the occluder for appendage occlusion. For PTA, we have all kind of absorbable occluder. And we also have the car. We can drive the car to the village to save more patients. And now we are developing the robot. We can use the robot on the car. We drive the car to the village, but the medical staff still sit in the big hospital. And we control the robot to perform the procedure. We have tried the procedure allocated in Beijing, in patient in Shenzhen and Kunming. So we also can perform this procedure. It's not a simple procedure for ASD or PFO. It's a complex procedure for mitral valve edge-to-edge repair. So it means that with the help of tele-robot procedure, we can save more patients. And that's the reason why today we are here. We appreciate the help from the United Nations to help us to work together. And about the program supported by the United Nations, the first is that a healthy screen. So we screen the patient in the village before the team arrive the village. So we find the patient and we check by echo. And then the team provide one-stop service. We perform the procedure in the local clinic or in the car to save the patient. After the procedure, the patient can go back home. So now for some percutaneous procedure, we didn't puncture the femoral way, we puncture the jugular way. So the patient can walk back home. And we also provide training program. The training program, just like today, is also a part of the training program. We provide the training in the different country. And today and tomorrow, we will have almost 20 patients. We will work with you together, hand by hand. We hope that you can learn how to perform this procedure. And we also provide financial support for you to visit Beijing to receive 6 months or 1 year's training, just like Dr. Jaffa have finished the training in Beijing. So we hope that more medical staff can use the effective and safety procedure to save more patients with the same budget. Thank you so much.
Thank you, Dr. Pan. I hope that this technology will develop more and more by the day and can be used in all over the world and can heal the patient's life and get them better. So the second speaker will be Dr. Zufaro. he's going to talk about interventional procedures in patients with congenital heart diseases in Uzbekistan. Thank you.
Good morning, dear ladies and gentlemen, dear chairman, dear colleagues. First of all, I would like to say our many thanks to the Professor Pan for initiating such a large-scale event in our region. And of course, many thanks to United Nations Development Departments for supporting this project. Мои слайды, пожалуйста. У меня в компьютере нет моих слайдов.
I don't have my slides. Please, my slides on screen. I don't see my slides in computer.
I'm sorry, some delay, some problem. Не проходит следующий слайд.
So I'm not able to move to the next slide. So please, technical personnel, please advise what to do.
Okay, thank you very much. Uzbekistan is the most populated among the Central Asian countries. Currently, more than 36 million population live in Uzbekistan. The population growth is almost 1% per year. Children make up almost one-fourth of the total population. And cardiovascular disease is still leading cause of mortality and disability. Cardiovascular disease mortality is about 56% and disability over than 25%. And every year in our country, 6,000 newborns have a congenital heart diseases. Next slide. At present, we've got 50 cath labs in our country, and there is, last year we see many cath labs open the private hospitals. Today, total number of the doctors in interventional cardiology is more than 300 specialists. Slide. And everyone knows that is development of the interventional cardiology depend on the availability of cath labs. Today we've got 50 cath labs in our country, and total number of doctors are already more than 300. Next slide. But just few years before, 6 years before, we've got only 4 cath labs in our country with 6 angiomations. Today we see rapid growing of these cath labs. It supports us to introduce new technology in our field. Next slide. Не, вы отстаете очень сильно. Следующий слайд, это назад идете. Здесь тоже не проходит. Следующий слайд. Следующий слайд.
Can you change the slides, please?
А вот здесь проходит. Надо где проходит?
Вот у нее отниматься вы видите?
Подожди.
По одному надо нажимать. Не то,
Today,
не то нажимаете.
все нормально. Today we
Сегодня мы видим, в прошлом году в этих лабораториях катетеризация была проведена около 508 тысяч диагностических интервенционных вмешательств. Большинство из них были коронарными вмешательствами. Около 1500 вмешательств было проведено у пациентов с ИБС. В прошлом году, в последние годы мы увидели большую поддержку от агентства по интервенционной кардиологии. Я хотел показать одну из них. Это был указ президента в октябре 2021 года. В нем предусмотрено, что начиная с 2022 года, исходя из потребностей лаборатории катетеризации, из государственного бюджета будет закупаться 2500 окклюзеров в год. Эта диаграмма показывает значительный рост числа имплантаций окклюзеров после обеспечения поставок наших лабораторий катетеризации. А в прошлом году в нашей стране было проведено более 1000 имплантаций окклюзеров у пациентов с ВПС. Вот началось, видите, 800, в прошлом году сделали больше 1000 вот этих случаев. Вы можете спросить, как насчет процедуры ПАН в Узбекистане? Первое закрытое ДМП было сделано по процедуре ПАН. В 2018 году первое ЧМТК рассеянного склероза у беременной женщины по процедуре ПАН была проведена доктором ПАН в 1918 году. Первое закрытие ОАП с использованием окклюдера по процедуре ПАН было выполнено в 2019 году. Не в 1900, а правильно в 2019 году. Да, в настоящее время нашими врачами, прошедшими обучение в учебном центре города ПАНа, госпиталя Фувай в Китае, было проведено около 100 случаев закрытия ДМПП с помощью процедуры ПАН. Надеюсь, сегодняшний симпозиум откроет новые возможности для процедуры ПАН в наших странах. И позвольте завершить мою презентацию следующими слайдами. Вот эту беременную женщину с тяжелым рассеянным склерозом впервые прооперировал доктор Пан 15 ноября 2018 года в нашем центре. И успешно все было. И видите, через 8 лет у нее мальчик. Она успешно родила здорового ребенка в марте следующего года. И вот она здесь. Я думаю, что доктор Пан, эта женщина, хочет вам сказать несколько слов. Она здесь. She's our patient. She wants to tell you a few words. Thank you for your attention.
Assalamu alaikum. shifokorlar, assalomu alaykum, doktor Pan. Meni hayotga qaytargan, mana shu farzandimni tug'ilishiga sababchi bo'lgan mana shu doktor Panga alohida minnatdorchilik bildiraman. Bu inson meni o'zimni, nafaqat o'zimni, balki farzandimni ham saqlab qo'ygan. Mana tug'ildi, 6 yoshga to'ldi. Rahmat mana shu xitoylik shifokorlarimizga. Mana shuncha yildan buyon ham bizni esdan chiqarmabdi. Biz ham doim doktor Panda bu xitoylik deb katta qilganmiz bu bolani. Rahmat shu doktorga ilohim.
Thank you very much.
Dr. Pan, I like translation. Everybody in his village say it is Chinese girl, Chinese boy. So, he look, he is thinking many things, and always your procedure, you're in the heart of this family. Thank you very much.
Yeah, it's very surprised. I remember just now I have mentioned this story. So I still remember it's 7 years ago. Yes. And that day we have finished more than 8 cases. It's the last case.
Mostly was HD case, all that.
Okay, so
it was not in plan.
So it's you. You tell me that. You told me that they still have another special patient, but the team didn't have lunch, didn't have dinner. The team is tired out. But you told me that it's a very special patient. The patient is a pregnant woman.
Yes.
Right.
But in the end, in dinner you had double lunch.
Double
You
lunch.
remember?
So the patient, when I see the mother is on the chair. So you cannot walk by yourself, and the baby is still in the mother's abdomen. So we perform the PAM procedure. We use only echo to open the mitral valve. This is the typical rheumatic heart disease. We open the mitral valve, so the patient can deliver the baby safely. So it's wonderful. So you are the witness of the friendship between Uzbekistan and China. Long life for the friendship.
All the time we are talking about cases, patients, numbers, 100, 1,000, 10,000, but every life matters. It's, as a doctor, very nice to see such kind of thank and grateful. Yeah. Thank you, Dr. Pal.
Dear colleagues, next speaker is Dr. Professor Ibrahim from Turkey with the PAN procedure in Turkey.
Thank you. Assalamu alaikum, and for Chinese friends, ni hao. Good morning, everyone. I am going to talk about interventions, percutaneous non-fluoroscopic interventions in my country, and in the future expectations, what will we hope and to develop. So, also Dr. Pan mentioned that we are using fluoroscopy for closing such defects, and the effects of the radiation is very important, especially on the kids. These are both deterministic and stochastic effects that can be resulted as soon as possible after the procedure, and sometimes they can affect like cancer in the long term. So we have to minimize these risks of the radiation. what can we do? We can reduce the fluoroscopy time, shorten the procedure, and also we can use just echo for these kind of procedures. Our clinical experience started in 2014, and we just curious about how to reduce the radiation dose in children after PDA closure. So we publish an article and do the echo sometimes of the procedure and not use the fluoroscopy. And then we think about how to reduce during the ASD closure. So we reduce the radiation dose to 3.75 frames per second and publish this and also presented in our national meeting. But we can even reduce the radiation dose. So these procedures, non-fluoroscopic procedures, can eliminate all the radiation, and we are also using this kind of technology, similar technology, in electrophysiologic studies like EnSight or CARTO systems. And echocardiography can be used also in interventional cardiology. So also Dr. Pam mentioned what kind of procedures can be done by echo, just echo, ASD, PFO, VSD. As the lady here, like mitral stenosis, mitral balloon, left atrial appendage closure, pericardiocentesis, and even more, like he mentioned, pacemaker implantation, other mitral clips, tricuspid clips, and some kind of valve implantations can be done once you get experience. So my journey started in 2017. I went to Fuai Hospital, and we observed non-fluoroscopic procedures. Then I contacted with Dr. Pan and worked there like 1.5 months. And at there I saw ASD closure, mitral balloon, and pulmonary balloon valvuloplasty. So as a doctor and a professor, it's important not to learn something, but once you learn, you have to go to your country and teach the others. So this is in Turkish, but in 2019, this is our national meeting. So I presented there echo-guided ASD closure, how we do it, and what's the points and what we need to take care of. And then same year, at the end of the year, there was a program in Istanbul. It is for complex ASD and expanding the borders and how can we close ASD. This is an international meeting, so I had a speech about the PAN procedure. So actually this kind of procedures for ASD was first done in 2020, was Dr. Peter Ewert, but it was not so popular by the time it decreased by not only ASD, but in the future they close VSD, PDA, and nowadays we know that PDA, especially in the premature babies, you go to a province that don't have cath lab, you just go with echo and close the PDA in a even 1 kilogram baby. I will pass this, and what will continue then, you know, everybody knows there will be a COVID, so 1 or 2 years was a little silent for us, but in 2023 in Chinese Heart Congress, there was a mitral valve clips and echocardiographic treatment of the tricuspid clips. So this PICS is one of the biggest meetings in pediatric cardiology, and it's held in USA, but for the last 2 times it was held in Turkey. One of the sessions is closure of ASD without fluoroscopy. So I was the moderator at there, and also online scientific program was there, and closure from Fuai Hospital was presented there, and we all discussed. And last year, that was the first workshop for the PAM procedure, and this is the second workshop, as Dr. Pam mentioned, was held in Turkey. So far we closed more than 100 ASDs, and also yesterday with Dr. Alisher, we tried to close 1 ASD without fluoroscopy. There are still some challenges, and we need eco guidance, as Dr. Pan mentioned. The most important thing is the eco guide, because you can close ASD as a single man in the cath lab with fluoroscopy, but if you don't use fluoroscopy, you need echo guidance. And the echo guy should be very, very experienced. And what will happen after ASD closure? So you get used to use fluoroscopy and then get experience and then reduce to fluoroscopy from my point of view, and then use non-fluoroscopic methods and then teach the others. What about future? We are planning to close PDA and pulmonary balloon. And what we need to improve this technology, we need guidelines, books. Also, last year in Turkey, PICS meeting, they presented a book which is written just for non-fluoroscopic procedures, and also teaching videos which can be online, and anybody can go log in and see what's going on and how does they handle. Devices like Panna device, yes, we can use this device in ASD closure, but what about the other procedures? I think it can be also used in mitral balloon, but what about the pulmonary balloon or VSD closure or etc.? And also, they mentioned that more than 30 country residents go to China Huawei to have this education, and it can be increased. And also, the people from China can come to other centers for some time, like 1 month or 2 months, and then teach what's going on there. Thank you.
Следующая презентация, доктор.
Next presentation, Dr. Vanas Georgievich, capacity of non-fluoroscopic closure of defects and preparing arterial flows. Preparing this presentation, I was looking for research, and my presentation was based on my experience and understanding of this problem, because to come to non-fluoroscopic methods of septal defect, we need to have big experience and understanding of this problem of closing defects of patent ductus arteriosus. When you closed thousands of patients with these abnormalities, because every patient has its own specifics which must be followed and dealt with. That's why those experienced people who are dealing with endovascular closure of such defects can start non-fluoroscopic defects using these surgeries, these procedures. So what do we know? Septal defects and patent ductus arterial, PDA, are the most common congenital heart defects requiring surgical or endovascular treatment. Traditionally, we all do this procedure under control, under angiographic guidance, using results of operation of surgery. Over the past years, there have been reports and possibility of septal closure defects using non-fluoroscopical methods under control of various endocardiography methods, TT echo CG, T echo CG, I echo CG, which are actively promoted by Chinese colleagues headed by Dr. Pan, called PAN procedures. And it's important to speak about these current methods. People spoke a lot about it, but I think it's very important to talk about training of people who would then do these procedures. The atrial septal defect is most common defects, which is treated endovascularly. 85–90% of the patients with secondary defects could be treated by endovascular closure. It's very important to see this distribution of defects, which allows us to speak the same language And it is very important to analyze the defects before the surgery, make very thorough transthecal control, echocardiographical, and transesophageal, because during the procedure you need to understand which procedure you follow to closure, whether you use some technical procedures or not, and what devices you will have to use to perform these procedures. All of that is very important to plan the surgery. And now, when the closure of small or medium-sized ASDs does not present any serious difficulties, and previous studies have shown comparable results with when eliminating them by surgical or endovascular methods. Patients with such defects are the most optimal for performing the PAN procedures because they're very difficult for previous procedures. And such defects as small, medium-sized are standard defects which must and are possible to be performed under the echocardiography control. Appearance of new toolbox allows to clearly control the position of your devices inside your hearts using the spindle-shaped tips. Improves the efficiency a lot in these procedures. And using these methods, it goes through the vein, catheter, and then implantation of a occluder, and it is all very good, excellent. We can close small mid defects using the PAN methods without any problems. It's very good, but there's a group of patients when so-called anatomically complex forms of ASDs, especially large ones, they present certain difficulties and is a factor of successful endovascular closure both under X-ray control and under endocardiographic guidance. So could be large defects, mobile, aneurysma, absent anterior superior margin of the aorta in combination with a small or unstable posterior or inferior margin of ASD. So those who do this closure, they know that there are some underground tensions and problems to do that, and we need to approach that with our experience. So let's talk about the large anatomically complex forms of ASD, and we use different methods, technical methods, that we can implant this defect. One of such options is Wahab technique, as occludocentric defects was used with the second catheter, a delivery catheter, which holds the disc, allowing to do the closure. I think that during PAN procedure, this procedure is very complex, or rather not possible. In a number of cases, we are using occluder from the left superior lobe pulmonary vein. As I was showing the video, this methodology is possible using PAN procedure because the lobe's pulmonary vein is well fixed, and possibly such defects using such methodology are possible to make the closure. It will be much difficult to close the defects using the fixation of occluder in the right upper lobe pulmonary vein, because the right upper lobe pulmonary vein is more difficult to be controlled with ultrasound. It is not recommended to use this procedure under ultrasound control. The correct selection of patients has primary importance in procedures of closure. One more methodology of closing the ASD using balloon occluder support. When under the inflated balloon, occluder is implanted, the then balloon is exflated, and in a number of cases such opportunity is possible using the pure closure of ultrasound control. But there are some patients who anatomically are very hard to deal with, like adult, 65 years, shunting, angioplastics of coronary arteries, visualization is difficult, In such case, using PAN methodology is undesirable. First of all, we need to think about the safety and efficiency of the procedure. We must be sure that having closure of purely under ultrasound control, we can close such defects. So, the correct assessment of defects, the correct planning of procedure and surgeries are of primary importance in both closure under X-ray and fluoroscopic methods. There are two defects as defects located far apart. In such cases, we are using two occluders, and possibly it would be difficult. Maybe Dr. Pan would be able to do the surgery himself, but we are just starting to do this procedure under ultrasound. We would not do that. I would rather do this under X-ray control, you know. In case when there are two defectors are close to each other, closing by one device is possible, and according to PAN procedure.
Also, here we can see the closure of the defect in the aneurysm of the interarterial septum. So we know there is sometimes a combination of what we can see in our practice, and in this case they will be located in one project, but there is no such method. But when there are some cases of multiple defects and also mobile aneurysm, so we need to choose and plan the procedures when we conduct it, because we need to make sure it will be successful. The example of the patient, when we wanted to close it, then we have catheterization of a second defect, implant of conclusion, and of course all this was specially designed for these defects, and the good result we achieved. Here we have VSD is one of the most common defects. We all well know these defects. In the slide you can see echocardiographic classification of perimembranous verticular septal. So we have to fully understand the anatomy of the defect when we conduct such procedures. In addition to that, there is also angiographic classification by the shape, because it also will identify our opportunities and what kind of methods we will use for the closure. And very often we can see also such defects that will have different shapes and different enclosures, and therefore we have to plan and fully understand how we will use the closure in which defect. Here in our arsenal we have the methods of closure of VSD. Most of them is traditionally antegrade transvenous closure, and recently becoming more easy for us to use the PAN method at a retrograde transarterial closure. So we have to fully understand all the equipment that we have for the closure of VSD. One of them, of course, we have different types, as you can see, single disc, double disc occludes, and also we have different shapes, double disc asymmetrical, asymmetrical. So therefore we have to have a good understanding and to use what is available in our clinic. Here you can see what is available in our clinic, which is widely used, and they are used for the closure of VSD. All the basically producers that exist on the market. What are advantages of ventricular septal defect integrated transvenous closure? First of all, it's a low risk of vascular arterial complication in young children, and also it's a good control over aortic valve function before disconnecting the device. There are some flaws as well. One of them is the need to create a monorailic system. We have this system, and it's very hard to see the function of the valve. Damage may occur aortic wave and difficulty in assessing this valve. And when we talk about now the advantages and flaws of retrograde transarterial closure, of course, the advantages you can see here: use only double disc symmetrical device, also good control of tricuspid wave function, valves before disconnecting the device, and no need to create a monorail system. And of course, there are flaws, as I mentioned already, and difficulty in assessing the function aortic valve, so the need of a second arterial access to perform left verticillography, and risk of vascular complications. So when we talk about PAN procedures, the most successful, of course, is access. When we use symmetric discs and they are easy to control using ultrasound. And we should understand here that a single disc we are not able to use more likely, and the more optical will be symmetrical. So here you can see how it's done. And we can see the closures, that after implementation of the closure, there is not enough sufficient for the clamp. And therefore, it is possible to use this method for the closures. And the closing of the here you can see the successful implantation of occluder, and it can be used using the method of PAN. So if we look at the evolution of this, you know, it started in 67. Now we have different type of equipment that we can use for the closure regardless of the shape and the size, so we're able to close all types of closure. It's very important to understand the anatomy because based on the classification of PDA, we have to accordingly use. With the PAN procedures, of course, again, here we have transvenous access, and also here we can say double discs device. And here we can see also the difficulty with the PAN procedure. In our clinic, we are not ready to conduct such procedures using ultrasound. Also, if the patient has lungs issues or the closure of the large defects with maybe it's not recommended to use ultrasound. Therefore, we have to conduct this operation taking individual approach. But the closure of the PDA by transarterial access using also PAN, as you can see, they also help us successfully to have the closure. This is one of our clinical case together with PAN professor. Here you can see we closed it with the occluder. After the closure, in 2 days, we started to evaluate the performance of this, but we saw, you can see, some situations that we were not satisfied, so we removed this device and closed. So currently in our clinic, we operated already 5 patients with different heart disease. So most of them, they have a good results. On the 20th of December, the PAN team visited our clinic, and together with them, we operated successfully using this method. And as I mentioned, 2 of such operations were conducted after the visit of PAN group. Thank you for your attention.
Sanol, are there any questions?
I have a question. Доктор Манолис, сейчас очень хорошо развито именно...
Now we have really developed for children that were born earlier in Europe, in America. They use transcatheter and also using ultrasound, and it's developing these methods. What's your opinion? We have such experience of conducted of such patients with underweight children. We have 5 patients. 4 of these patients, everything was successfully using also the method. It's echocardiogram was the main method when we try to evaluate the position to make sure not to provoke obstruction. It was very important to evaluate it, but in the first case we put the occluder ideally, everything was good, but the next day with echo control the occluder was in place, but in 2 days the patient was received because occluder was dislocated, and therefore what I would like to say, there is a dynamic opening for children that are already underweight, early delivered. So if it's possible, we need to make sure that we avoid dislocation, but perspective is very great. The one patient that we conducted was only 700 grams. I have also one more question. Could you please tell us, it was a slide, when you look at the patient, why it was such a large defect was not closed? How it happened? Unfortunately, there are such situations when it's difficult to explain why we have such big defects after the operation on heart, especially in case then this patient had also the plastic of neutral clapping. So it's hard to say, but this is a situation that occurred, and that's the case that we had. But anyway, we use the occluder with a diameter of 40 millimeters, and of course it was hard to do, but it is possible. So that's why people should be ready to all different type of defects. The qualification of the doctor will depend on, like today when we promote the PAN method, it's not like you should come after this event and go to echocardio room, but you should be prepared to have appropriate approach. So the specialists should be trained accordingly. And of course, it depends on you. It's also 2 people involved, the surgeon and also the cardio echo specialist, because if you don't have a good quality of the specialist, it's a job that required cooperation. So they should understand what you want, what kind of projection to show, and also to control your actions, because they understand more. For example, so she needs to say this can be dangerous to do, And that's why it should be a teamwork.
He's from Turkmenistan, Dr. Baram Kadirov, as my family.
Добрый день, уважаемые коллеги. Наверное, я тоже...
Dear colleagues, if you let me, I will continue in Russian because I believe that here more present. So first of all, I would like to thank for invitation of our team. We are very closely collaborate with you, and it's my honor to be here and to talk about regional scientific symposium and the global trends in the stereofluoroscopy cardiac intervention. And we will talk today about how the importance of zero fluoroscopy evaluation of the system, global trends in the world in the future. So that's a plan that you can see. I would like to show you the importance of zero fluoroscopy and evolution that took place, how it's changed our day and the global trends in this method, and also what is ahead of us. The method of zero fluoroscopy is increasing number of interventions in patients with cognitional heart defects and arrhythmic. Children and young patients are particularly vulnerable, and therefore we have to use the method that will be more safe with less radiation, occupational risk for operators, also very important, and it's a model clinical guidance support reducing radiation exposure. Here you can see that the less is the dose, it's better is for a patient, and it's also good for the staff. On the next slide, I would like to show you the new technologies that we can use. It's a 3D electroanatomical mapping, also ICE and TTE and TEE. That's for cardio interventions. More advanced that we use as a CT and MR imaging modalities and new generation. As you can see, they help us to fully plan the procedure from the beginning, and of course, especially for those who have the complex and new general aerobic assistance. And here you can see the future. We already observe a lot, and we can see a lot of systems that are used currently, like Enabler, for example, which are known. So what the Dr. Pan and his team, they started the project. They also mentioned that each year there is an increase of different defects and what Pan procedures are suitable for. So here I would like to see the analysis that was published in 2025. So there was a special research done, clinical research done. As you can see, 97% was successful rate, and over 7,500 patients were involved. There was non-fluoroscopic group consists of 8 studies, and here you can see on the next slide, and also a publication 78 fluoroscopic and 70 fluoroscopic guided PDA closure, and as you can see 99% was success rate. There was no difference, and also no complication rate is about the same. The next slide it's Dr. Anton Heinerberg is our friend. He visited our clinic quite a lot in the 2006 and 2009. He started to use this method. It was 140 patients using non and this interface was very successful. So the next, what was done by also, it's 260 patients were undergone PPM or ICD implantations using the low dose fluoroscopy technique, and the 2006 matched control. So as you can see, the time is 49 minutes in the first group and 65 minutes in the second group, and there was not a big difference, but there was a reduction of radiation, as you can see, very high, and therefore they did not receive complications. At the same time, another research was done.
So one more research was done, published also in 2022. Zero fluoroscopy ablation. So they were using this fluoroscopy and see how many patients were performed. It was a very good result, and there was no big complications. So one more research, which was published in 2021. 16 big studies were made since 2013 until 2020, included over 6,000 patients. With the conventional F and low fluoroscopy, there were no significant differences in acute procedure success rate, peri-procedural complications, recurrence-free. So what shall we think for the future? Of course, moving forward, continue training young people. Of course, integration with artificial intellect, intelligence, AI. It's important for all of us, young experts, and also using augmented reality, virtual reality in procedures, development of miniature wireless catheters and sensors, which would be even more efficient, and also we would be establishing regional registries for zero fluoro procedures, which would include the methodology and improve the results of treatment. What is important for us to continue and moving forward, continue training programs of young experts and young specialists independent of fluoroscopic guidance, supporting center transitions to zero fluoroscopy with grants and educational programs. We also must support international collaboration, join registries and multi-center trials, which would help global transition to safer methods. And at the end, I would like to say very important work of Dr. Pan and his team has shown that fluoroscopy methods are important for structure diseases. Their work show potential methods to improve the quality of treatment and reducing radiation risks. Let's continue to work together to make this method a standard for cardiological interference. Thank you very much for your attention.
We are out of time, that's why we cannot have any questions. And the next speaker is Dr. Kadyrova. She's going to present the using of pump procedure for AC closure in pediatric patients in Kazakhstan.
Good morning, dear colleagues. Good morning, dear colleagues. I'm working in Astana for Heart Center, and I'm so happy to be here in this symposium. Thank you. First, I would like a little bit to report about the progress of development of cardiac surgery and percutaneous interventions in our country. In 2006, only in three hospitals, open surgery were performed, but now it has been done in 34 hospitals. And the number of open heart surgery over the period of 2010 and 2022 from 5,000 increased to 11,000. And the number of percutaneous interventions from 6,000 in 2010 increased to 100,000 in 2022 years. So, so in our country, our clinics are very good equipped with angiographers, and 29 angiography equipments had our country's hospitals. Only in our hospital 6 cath labs, and last year 9,500 interventions were done by us. But now we are so interested in developing of a non-fluoroscopic pan procedure in our hospital, and from that the reason first was interested to work with biodegradable occluders, which are visible only by echo. And for this reason, we visited a hospital, Hubei Hospital in China, in January of this year, which we are well-developed non-fluoroscopy procedure under the guidance of Professor Pan. So why you need the non-fluoroscopic pan procedures? First reason is patients, especially our children, can escape unwanted X-ray effectors during the procedures. For example, as a Journal of Cardiology in 1992 shows that operators, doctors are well protected during the procedure from X-ray effectors, while patients are not. So next reason is patients cannot, in our country, can live in their cities, and our doctors can go there and perform interventions by echo in any operation rooms of regional hospitals. And it's especially for patients with critical balloon valvuloplasty, aortic or pulmonary valvuloplasty, and other defects closure. So next reason is not need to wear heavy protective clothing during the procedure. And last one is it's a new opportunity to open new department where many interventions will be done under echo, and thus freeing up cath labs for other fluoroscopic procedures as malformation of fistula closure or pulmonary branch station and PCI. So here I say you that non-fluoroscopic echo-guided procedure is not new for Kazakhstan. We last 10 years all Rashkinda procedure in emergency care department do only under echo very successfully. It's a patient's infants with critical condition. And as the closure, we start the process has begun now, and with the PDP for valvuloplasty in children, a TAVI mitral procedure in adults, we are planning for the future. Here I'd like to say the fluoroscopic treatment intervention, some of pathologists to find out how many cases we can in future do under TT or TEE. According to the data, we can do 400 or 500 cases and only under echo. For this period, only for 2 months after China, we did 10 cases, patient in the closed ASD in children. Only 10 cases because of the absence of PAN wires, but we are waiting for these wires and we'll continue soon. So here you see that medium age 8, our children from 2As till 15, and ASD size was 1 centimeter from 6 to 15 millimeters, no complication, and the time of intervention only by echo was 40 minutes. So here I'd like to show one cases by detailing. So you see here the central defect of central type of atrial septal defect, diameter 10 millimeters, and we are here in subcostal long axis view. You see PAN wires and catheter, multi-Phillips catheter. PAN wire is in left atrium. You can rotate catheter, first withdraw PAN wire and rotate catheter, insert catheter through ASD from right atrium to left atrium, and as a short axis view and apical for chamber views is good for this action. So it is very important to come into pulmonary vein, and because we use our clinic recommended to use for children balloon sizing of ASD to avoid overstretching of defects and to avoid oversizing occluders. So here we can see the balloon waist size, and the size balloon waist on echo is the same on fluoroscopy. You did some fluoroscopy for some patients to compare this measurement, and we do not take occluders more than balloon waist size. It is for children very good, I think. So here you see first that defect on balloon waist was 12.8 on echo, and here we implanted 13 size occluder. After to escape residual shunt and damaging of surrounding structures as pulmonary vein, mitral valve, you can see we can control occluders and the other structures for short axis view, subcostal, and for apical for chambers view well. So it's a time to make a conclusion. Non-fluoroscopic PAN procedure to close ASD in pediatric patients is feasible, safe, and effective procedure. Balloon sizing of ASD without overstretching of the defect on TEE helps to escape oversizing ASD in children. The size of the defect during balloon occlusion on transthoracic echocardiography corresponds to the size of the defect during balloon occlusion on fluoroscopy. Non-fluoroscopic procedure allows defects to be closed in a outpatient operating room in provinces or other cities of our country. Our country is too large. Where are no catheterization laboratories. A non-fluoroscopic procedure provides a good opportunity to use a biodegradable polymeric occluders for the closure of an atrial septal defect, as these new occluders are not visible under fluoroscopy. Non-fluoroscopic ASD closure is a first step for all non-fluoroscopic procedures for other interventions as VSD, P4, PDA, valvuloplasty in children, and P4 closure, TAVI, mitral cleft implantation in adults in future. So it's the photos of our lovely team. I will be very glad to see you anytime in Kazakhstan. Thank you so much for your attention.
Thank you, Professor Sauce. Thank you so much. Thank you for your wonderful picture. Okay. Okay. So, everybody, so I think this is the session for this morning. And I hope that in the afternoon, we also have another expert to give the presentation about how to perform the echo guide procedure. And today, we will screen the patient. They have arrived at the hospital. And this afternoon and tomorrow, we will have some procedure to see some patient because we have too many cases. And we also have a pregnant woman today. So we hope that we can learn more, and we also can say more. Okay. Okay. Thank you, everybody. Thank you.
Hurmatli, mana mashta o'tirgan zaldagi bizani xodimlar, mehmonlar. Mana bu yerda darvozadan chiqqanda o'ng qo'lda E'zoz degan restoran bor. Osh tayyor sizlar uchun hammanglarga. Hamma mashta o'tirganlar chiqadi-da, o'zi obedlanadi. Joyida o'sha yerda osh yeb, keyin ketasizlar. Tushuntira oldimmi? Гости, уважаемые, сегодня, сейчас вот мы приглашаем вас на обед, вот за воротами направо. Это английский.
Good morning, dear chairman and colleague. Because my oral English is not so good, please let me give a lecture in Chinese. 尊敬的各位来宾，我们今天
Уважаемые коллеги, сегодня я расскажу о радиационной опасности в традиционных категоризованных лабораториях, уделив особое внимание инновационной ценности зеленого кардиологического вмешательства.
What's wrong? 它不动。好。换一新的。OK，我们将分下面4个部分呢，来和大家进行分享。第一部分呢，就是我们对于这个放射性损害相关的诱发的一些疾病。大家知道，在1901年呢，这个诺贝尔奖的获得者伦琴呢发现了这个 X 线。X 线当然应用到这个医疗方面的应用了很多年，但是呢，它有带来的这个进步，同时也带来了一些问题。我们大家可以看到，在这个 CASLab 里面，我们这个放射线的这个剂量呢，相当于我们这个放疗的化疗病人的这个剂量。所以在导管室中，它接受的这 X 的剂量呢，和我们的组织损伤呢有非常密切的一个关系。同时，我们也可以看到，这个暴露在 X 线下呢，会有很多的这个导致损伤，包括皮肤、我们的眼睛晶体，还有包括我们其他的这种生殖腺和骨髓造血。第二部分呢，我们可以看到目前的这个介入治疗对放射治疗的医生暴露以后带来的一些问题和伤害。大家可以看到呢，随着我们这个参与放射治疗的医生和我们的护士，可以看到，特别是这个心脏和电生理的，他接受的辐射剂量呢，和我们的普通的医生和我们的技师比呢，它的放射剂量是显著增加。同时呢，它的癌症和我们的这个高血压以及我们其他一些慢性疾病的这个患病率呢，也明显的是高于我们的这个医生和我们的护士。主要是因为在操作过程中呢，还会有很多的这个要穿戴很多的防护设备，所以对我们的这个运动系统和我们的这个我们的骨骼呢，都造成了很多的损害。第二呢，我们也可以看到，随着这个从事介入的这个时间的增加，我们这种损害呢也是明显的来增加。可以看到它的这个低暴露剂量的工作人员和高暴露剂量的工作人员，他们的对于这种身体的这种损伤呢，表现出了明显的时间的这个依赖性。我们可以看到传统的这个介入治疗的这个缺点呢很多，比如像早上这个潘香斌院长所介绍的，他有非常就是他的这种可及性比较差，需要昂贵的放射性设备 和我们的导管室，而且呢，它很难在这个比较条件边远的地区呢进行我们这种介入治疗。同时呢，它有很多的这种影像学的这种限制，包括我们不能够必须要非常全面的来反映到我们的这个心脏这个结构，因为我们知道 X 线呢它是一个单平面2维的一个情况，同时呢不能实时的来监测我们的心脏。我们第3部分呢就是我们的这个潘院长倡导的这个绿色绿色这个介入的这种理念，特别是我们就是这个Pan Procedure 这个方法呢，目前是一个非常创新的一个在介入治疗中的一个方案。包括大家可以看到上午对于这个潘院长介绍的这种低辐射剂量，或者是没有无辐射的这种低伤害的安全的非常有效的这种心脏这种介入治疗。同时呢，这个绿色电生理的这个情况呢，也这种操作的方法呢，也在全世界各国家呢也逐渐得到推广。我们可以看到，我们举了下面的一些例子，典型的就是我们现在这个房颤的射频消融，我们可以用这个3D 的这种超声来进行我们相应的一个指导。同时呢，我们在这个房颤的这个电生理检查过程中呢，我们也可以来采用我们的这个潘氏的这种方法呢，来我们进行操作。下面是一些病例，包括我们的这个起搏器的这种植入，也可以在超声的实时监测下呢，能够完成。下面呢，我们会举一些例子来共同的给大家展示这项技术。包括我们这是房间隔穿刺，在超声的定位下、引导下呢，我们可以进行精准的这种穿刺，再结合 S 的情况下呢，我们完成了房颤这个射频消融。同时呢，我们大家可以看到，这是我们的左心耳封堵，左心耳封堵术呢，也可以通过我们的完全纯超声的导引下呢，我们来完成我们的这个左心耳的封堵。另外一个例子呢，是一个38岁的一个男性，我们在这个纯超声的导引下呢，完成了我们这个对于 ASD 的这个封堵。同时呢，我们也可以看到，这是26岁的另外一个病例，我们是在这个10道超声的这个监测下呢，我们完成了这个ASD 的这个封堵治疗。同时呢，这包括是我们的这个 VSD 的治疗 ，VSD 治疗呢，也是在纯超声的这种导引下呢，我们可以完成部分的这个 VSD 的这个治疗。这一个呢，是一个10岁大的一个男孩。这也是一个12岁的一个男孩，我们进行这个 VSD 的一个在超声下的一个封堵。这是一个 PDA 的一个封堵，这是23岁的一个男性的一个患者，我们在纯超声下呢，我们做了这个相应的这个封堵术。同时呢，对于我们也可以利用这 ICE 呢来监测指导我们这个 PFO 的这个来进行一个封堵的治疗。这个呢是一个现在潘院长在全国推广的，在中国推广的和全世界推广的一个在全世界这个在完全超声引导下的一个胎位的一个介入的一个治疗。这是78岁的一位老年的一个女性，我们来进行了一个胎位的一个治疗。大家可以看到，这个在超声引导下呢，我们的图像质量还是非常的清晰。这个例子呢，是我们是个66岁的一个女性，是2间半狭窄的一个病人呢。我们采用纯超声导引下呢，来进行这个2间半的这个球囊的一个扩张。这是75岁的一位女性，我们在纯超声导引下呢，我们进行了2间半的 MitraClip 的这个操作。我们可以看到，在2维和3维的指引下呢，可以非常清楚的看到我们这个2间半的这个后叶的这个脱垂， 我们呢来进行这个二尖瓣的这种前夹的操作。这是我们在这个 bicommissural 的这个切面和我们这个 LVOT 的这个切面来进行这个我们的这个 clip 的这个定位。大家可以看到，我们最后做完前夹以后呢，这个反流呢明显的减少。这是我们对于三尖瓣的这个Luxwave 的一个治疗，三尖瓣的一个置换。这是56岁的一个男性患者。我们可以看到置换完以后呢，可以看到非常清晰的这个瓣膜的形态，而且病人的这个反流呢明显的这个减轻。这一例呢是我们用在纯烧生导引下的一个肺动脉瓣的一个介入的一个治疗。所以这是个65岁的一个女性，通过这个纯烧生的这个治疗呢，我们也做了这个肺动脉瓣的一个成心术。最后一部分呢，就是我们对这个治疗的一个总结和它的一个反馈。大家可以看到，我们从最早的一个低剂量的一个指南，一直发展到现在，我们整个的一个指南对我们这个没有 X 线的这种绿色的介入的这种提倡，它的指南的级别呢级别越来越高，同时呢也得到了我们全世界各个国家的这种推广接受。而且呢，我们可以看到未来的这个我们的这个介入治疗，特别是在潘香斌院长的这个指导下呢，我们完成了0到1到100的这种变化。以前呢，我们的医生是要带非常多的这种防护的用具，包括铅衣。到现在呢，我们脱掉了我们的这个防护设备，我们可以非常轻松的来进行我们的介入治疗。未来呢，可能在超声引导下的这种绿色的这种介入治疗呢，可能是我们未来发展的一个非常有前景的方向。这是早上潘香斌院长来介绍的，在阜外医院，还有在各个国家的导管室呢来进行培训，各类的学员，希望使得这项技术呢能够惠及更多的这个国家的这个患者。最后呢做一个总结，就是我们的这个射线确实是对于医生来讲是这种医源性的这种损害。那我们如何来进行去做呢？我们现在就是一个新的方法，就是我们的pan procedure， 就是我们利用潘院长发明的这个绿色的这种电生理的方法呢，能够来完成我们的整个的这个介入治疗。也希望我们这个介入治疗呢能够更加的普及，能够让我们更多的患者能够接受到这项先进的这种治疗，也为我们的所有的医务人员呢能够保护我们自己，使我们免受到射线的这个伤害。谢谢大家的聆听。Thank you for your attention. Thank you.
Thank you, Dr. Yang. Are there any questions from the audiences? Okay, thank you. Now the next speaker is Dr. Liu from Shanghai Children's Center. He is going to talk about transcatheter closure of ASD in children using fully biodegradable occluders.
Okay, thank you, Chairman, and good afternoon, everyone. It's my pleasure to take part in this conference. Actually, it's my first time to visit so beautiful Tashkent, and of course, so delicious food. And for me, I think it must be a wonderful time and wonderful memories. I'm Dr. Liu from Shanghai Children's Medical Center, and now I want to share my very limited experience about the transcatheter closure of ASD in children use fully biodegradable occluders. Actually, biodegradable occluders, I think, is an inevitable trait in development of interventional therapy. I remember about nearly 30 years ago when we do the transcatheter closure of ASD use implant device. I think after we close the septal atrial septal defect, every doctor will have an idea. If we want to cross the septal, now we have a device, mental device in the septal. I think it may be a very, very difficult thing because nowadays we have many interventional procedures. We need to puncture the septal, such as the radio frequency ablation for the atrial fibrillation, the LA occlusion, and also the tear, and so many procedures. So just at the beginning of we use the mental device to close the septal, we have a dream when and how can we have a fully biodegradable occluder, because we want to intervention without implantation. I think it's a dream of all our doctors who do the interventional procedure. How to do the next step? Yeah?
For the next?
Yeah.
Turn back.
Yeah, okay. So, many institutions around the world are developing biodegradable occluders, including the partially and fully biodegradable occluders, such as in United States, in Singapore, in China, Taiwan. But unfortunately, almost every of this design have different kind of disadvantages. So therefore, till now, no product has been successfully approved for clinical use. But fortunately, in China, we found a product we can use since last year. That is the Memosob fully biodegradable occluder. And this product project began at 2013. And after more than 10 years research and development, and in last year, we say the biodegradable ASD occluder approved for market use. Memosob biodegradable ASD, we call it the BD ASD occluder. B means bio, and D means degradable. And it's a BD ASD occluder composed, simply said, is two parts. One part is the implant part, that means the skeleton by PDO. And the affiliated part is a nylon wire and a special lock device. So compared with the mental device, the PDO skeleton, after release from the sheath, have not so good memory shape compared with the mental device. So the left disc always like a mushroom when released from the sheath. So we use a nylon wire. When we release the first part of the device, that means the left disc. When we release the left disc, we withdraw the nylon wire to help the left disc more flatter, not just bulged like a mushroom, more flatter. And we draw back slowly until the left disc is parallel with the septal, and then compress the septal. And at this time, during the echo guidance, we make sure the left disc is compressed on septal. And then we withdraw the wire to lock the device. And then when after locked, the device will stable in the septal. And by the animal test, the tissue regenerative material and the structure design ensures completely and safe degradation of the occluder with no mental residue. And the PDO materials reduce the fibrosis and the inflammation, promotes industrialization and decrease thrombosis formation. And another special design is in the left side, we have no revent, is a reventless left disc. And this also help sorting the industrialization procedure. An RCT study of biodegradable ASD closure shows there's no difference, no significant difference between the successful rate. And the blue one is the test group, and the red one is the control group. We can see almost no significant difference, and technically successful rate is the same. And the safety indicators, the incidence of the arrhythmia in the test group was less than in the control group, and it's further decreased after 6 or 12 months later. And this is the ultrasound imaging. We can compare with the test group and the control group. In the first 3 months after implantation, the test group, we can see the typical sandwich structure and the echo. And after 6 months, it seemed more and more thin. Until 12 months later, we cannot see the sandwich structure. Of course, in the control group, the mental device always the sandwich structure. So, this data is from my hospital, and I remember the first case implanted with the fully BD-ASD closure is in December 30, almost the last day of the year 2024. And from the December 2024 to now, to April 2025, almost there are 13 cases of the closure using Microsoft occluder in our hospital. And age is from 3.5 to 15 years old, and weight from 15 kilo to 62, and height is from 103 to 168 centimeter. And the ASD maximum diameter is from 5.5 to 14 millimeter. And this is the whole data. You can see the smallest child we have done is 3.5 years old. The ASD diameter is 11. We use 16 millimeter BD ASD occluder, and the sheath we can see is 14 French sheath. And the first patient is a patient with a premature ventricular contract. So we do the radio frequency for the premature ventricular contract first, and then we do the transcatheter closure of the ASD, use BD ASD closure. And all patients under general anesthesia. And 3 cases echo-guided by the transesophageal echography, and 10 cases is guided by the transthoracic echography. And the technological successful rate is 100%. And only 1 case suffered from headache after 1 month of the implantation. And we put, except aspirin, we give Pavix with two kind of anticoagulation. And the follow-up is still to do. So actually, the longest follow-up type for in our serious patient is only 3 months. This is the imaging during the procedure. Actually, we use the fluoroscopy and the echo guidance together. So in our hospital, we want to learn more pan procedure. We want to use less fluoroscopy and more echo guidance. But actually, in the clinical work, we usually use fluoroscopy and echo together. I think for children, we have not so many so many methods to do just absolutely use echo guidance. I think for the safe, we usually use these two tools together. And this is the follow-up. 1 month follow-up, we can still see the sandwich structure. And 3 months, it seemed become more thin than the 1 month follow-up. So theoretically, this device is continually disappear after 12 months. But there may be some individual different of the time of the biodegradable. So our preliminary experience included the procedure fundamentally originated from traditional technique. And the learning curve relatively short, I think. For the most of the doctors who have the long training of the interventional procedure, I think use BD as the occluder is not so difficult. And another one is echo guidance is a key point, because compared with the mental device, this kind of device cannot shown by the fluoroscopy. And the Microsoft followed biodegradable occluders demonstrated optimal interfaces for the anatomically suitable small to medium ASD. I think for the children, for the first patient, we do the very strictly selection. So I think the typical central ASD, and not very big one, is the suitable candidate for this kind of device. In our study, the biggest one is about 14. Theoretically, for the children, more than 20 millimeter ASD may be very difficult for this kind of device. And another question is using large delivery sheaths remains a challenge in pediatric patients. So the smallest delivery sheath is 12 French, and when the device is more than 16, the first choice we use the delivery sheath is 16 French. 60 French is, I think, is a challenge for pediatric patient, especially for the low body weight patient. And another question is that the insurance coverage policy have also emerged as a critical considerations, because in China, the BD as occluder is much expensive than the normal mental device. So the insurance, I think, is also a problem. And the further questions concerned maybe, number one is the procedure convenience, reproducibility, and the safety of the whole occluder system, because the whole system is a little complicated than the mental devices. Another one is management strategies and infection complications associated with the degradable occluders, especially device migration. I think the dislocation of the device is a disaster for the doctors when we use the BD occluder, because we cannot see it by the fluoroscopy. I think it is a big problem we should consideration. And the degradation timeline and industrialization procedure post-implantation is actually different between different patients. And thrombosis risk related to occluders and corresponding anticoagulation protocol, which is the optimal one. Use single use of aspirin or combine use aspirin and Pavix and whatever. And the last one is safety and efficiency of degradable occluders for large and anatomical complete defects. I think is also very difficult thing. So I think we are always on the way to find idealist fully degradable materials. And this Chinese word is in Chinese 砥砺前行 by President Xi Jinping, and translated by DeepSeek is when the going gets tough, the tough gets going. I think we doctors is always on the way to find the better idealist fully occluders. Okay, thank you very much and welcome to Shanghai.
Thank you, Dr. Li. Yes. You can sit.
Thank you very much for a nice presentation. I would like to ask you, as a doctor, as a specialist, do you feel any difficulty when it's implantation, doing implantation? And what do you see when is the risk of dislocation a bit higher than our usual we use occlude or same? Two questions, please. And what about sizing? Sizing. Do you follow same rule? I mean, balloon sizing, it will go same size, or you have to go a bit bigger, smaller, 1-2 millimeter. These things, please. Could you explain my question?
Okay, thank you. Actually, I think compared with the mental device, the whole procedure is not so convenient as the mental device. So I think there are 2 points that are very difficult so to pay more attention to is the first one is after release of the left disc, we must make sure that the left disc is flatter and completely compressed in the left side of the septum. So, I mean, before we release the right side disc, so the left disc should be in a very good position. And if we release the left and right disc together in the left atrium, it will be very difficult then to withdraw and release again. And the second one is after the left disc is in a good position, we release the right disc, and when we lock it, it's a very important step. We withdraw the nylon wire until we completely locate the device. Then can we release the device and pull out the nylon. And then the second question I'm not completely understanding is
what do you mean? In ordinary case, we choose size according, for start, according sizing, balloon sizing.
Okay.
Always you follow in that, biodegradable occluders. Should be choose it same way or it is different way? Maybe you have to take bigger than ordinary device.
Okay, in our certain cases, we do not balloon size them. The reason is, first, all these 13 patients is strictly selected by the echo. It's typical central ASD. So, experimentally, when the size is below 10 millimeter, so from 5.5 millimeter to 10 millimeter, we use the device, the waist device, 6 millimeter bigger than the ASD device. It's just experimentally. And when the septal defect is more than 10 millimeter, we plus 8 millimeter. So, for example, 12 millimeter ASD, we use 20 BD-ASD colloidal. So we did not do the balloon sizing.
I have 2 questions. Yeah, thank you. Oh, go.
Okay. Okay, too many questions.
Спасибо большое.
Thank you very much. Many questions. But do we have time for discussions or not? We have many questions, but do we have time for the questions? We have many questions, but do we have time for questions? As far as I understood, you don't measure defect by balloon. You only focus only ultrasound data. So if you take over size from 6 to 8 millimeters from defect size, if it's a small child and a large defect, what you are going to do?
Oversize may be the truth, but if very small baby have big ASD, I think it's not suitable for the BD ASD occluder. I will try mental device.
То есть металлический
Metallic occluder, metal occluder, yes?
For the small baby with big ASD.
Почему такие вы показывали?
In your presentation, you were showing big delivery systems, 12, 14 French, and size of defects were small. You always have to take large delivery system. And why so large? Because you're afraid to damage the occluder?
You know, the BD is occluder. The smallest delivery system is 12 French. So even we use the smallest device, we still use 12 French delivery system. I think it's also a very big challenge for us to use BD occluder for the pediatric patient. So this kind of device need a relatively very big delivery system.
Окклюдер находится.
Is occluder on the development stage and clinical test trial, correct? Can we simplify visualization of the device sewing some metal ethanol threads just to have some framework of the device? It would be important if there would be some complications like device migration, so it would be possible to remove them.
Some doctors met these complications, but not for me. I heard some people, in some cases, when the device is dislocation, and there's some cases can be withdrawn, use the interventional procedure, use a snare or something else. I think it's very difficult.
Просто говорю.
What I'm trying to say, can we simplify this device sewing some metal metal threads?
In a device? Yeah, okay.
Yes, yes, yes.
There's two kinds of BD ASD occluder. The BD ASD occluder 1 have 5-point mental marker, and the BD ASD occluder, the second generation, have no mental marker. It is the fully biodegradable occluder. And in the first generation of the BD ASD occluder, there's 5-point mental markers.
Как вы думаете?
Do you think we already have the ideal device? Ideal or not yet?
For the anatomical suitable ASD, I think it is a good one. But it is determined by doctors. We should do the very strict selection for good candidate.
Конечный продукт.
The final product of these occluders would be what? What would be the danger if the biodegradation would go wrong? Because I don't know what is the composition of this device. the degradation products are what? Hydrogen or water? What it turns into after degradation?
Material is called PDO. I think the engineer will connect with you and send more detailed materials about this kind of what is the BTO. Actually, I don't know.
As a pediatric cardiologist, we close the defects, but the adult cardiologists say that in the future these kids might have atrial fibrillation, and we have to do transseptal puncture.
Yeah.
So during transseptal puncture, if you close the ASD with the device, it is much harder. So could it be possible to transseptal puncture, or how this device make the endothelialization? Is it so thick, it's like PTFA, or like just a membrane, or just a tissue? Did you try it?
You mean this?
Yes, after, for example, you implanted this into a pig, and then wait 2 years, 5 years, then
yeah,
do
maybe
a
the tissue.
transseptal
I think
puncture.
when
Yes.
we puncture the septal, it should be easier than use a mental device.
Okay.
Yeah.
So
I hope this audio-list materials, but actually, no one knows. Maybe we have the more better one.
So actually, there is no nowadays ideal ASD closure device. I usually select them according to the patient size, and also, for example, no aortic rim. So I can use a softer device like Occlutech, LifeTech. But if the rims are okay, so I may go with Amplacell, Lepo, other devices. So also, maybe in the future, biodegradable devices can be selected according to the patient's anatomy, I guess.
Yeah.
Once we will see the trials, then probably it will be better soon. So the next speech is from Dr. Wang, progress of pump procedure, what can be done today?
Okay, thank you. It's my pleasure to introduce the progress of PAM procedure and what can be done by per procedure now. So I will jump over the background because Dr. Pan has introduced the background and the advantagement of the PAM procedure. I cannot control the slides. Okay, use this one. Okay. Okay, let's go directly into the latest progress of PAM procedure. In the initial stage, we can complete the device closure procedure for congenital heart disease, like ASD, PDA, VSD. And then we use PAM procedure to perform balloon valvular plasticity procedure for mitral valve stenosis, pulmonary valve stenosis, aortic valve stenosis. And then we use the PAM procedure to complete some new procedure like the transcatheter mitral valve replacement procedure. And the latest progress of the PAM procedure is that we can use the only echo to supply guide for the TEER procedure. That means the transcatheter edge-to-edge repair for mitral valve and for tricuspid valve, and also the echo-guided TAVR procedure, and even the echo-guided procedures for arrhythmia. So let's go to the first, how to do the mitral TEER procedure with pure echo guidance. As we all know that the TEER procedure is now the most important treatment for the MR patients, especially with high risk for surgery. And we all know that this procedure should be done under both X-ray and echo guidance. But now we can complete this procedure with only echo guidance. Here are some tips how to do this procedure with only echo guidance. The first tip is how to insert the guide wire into the superior cave. And we always use the bicaval view of TEE to show the process that you can see it very clearly. The guide wire passed through the inferior cave into the right atrium, then into the superior cave. This is the first. And another tip is how to insert the guide wire into the left superior pulmonary vein. And we always use the bicommissural view or short axis view to show the left superior pulmonary vein and the LAA. And you can see very clearly. And if you are familiar with this echo view, sometimes even you will find it's more easier to insert the guide wire into the left pulmonary vein more easier than with the fluoroscopy guidance. It's very, I think it's a really a good news for this procedure. And if it's very difficult to complete this step, we also can use some special wire with circles on its tip, just like we use the wire for the PVMV. Okay, maybe there's some on the video. So the next tip is how to complete the straddle step. We all know that this step is very important when you do TEER procedure. It means that the second catheter, the curved part of the second catheter is totally out of the first catheter. It's very important. Or the circle or the flex of the second catheter will not be accurate. So under the fluoroscopy, we can see 3 markers, and then we can complete the straddle step. But at the echo guidance, we cannot see these 3 markers. But we can estimate this relationship when we are very familiar with the device, and we can estimate it according to the relationship between the first and the second catheter beyond the patient. And for the new devices from China, and there will be some markers on the second catheter indicate whether the second catheter and the first catheter are in right relationship. And the first tip is how to adjust the trajectory. Yeah, it's very important for the TEER procedure. If the trajectory is not good, the clip cannot be implanted very well into the mitral valve. So we always use a 2-dimension view to show the trajectory of the system, but sometimes it's not very clear. Always we can use the 3D view to show the whole trajectory of the CDS. You can see it's very clear to see the movement of the device. And we also have completed the film study about the TEER procedure with only echo guidance. Yeah, the initial study showed that with only echo guidance, we can achieve the same effect or same results with the fluoroscopy and echo guidance together. There's the result of the MR or result of the heart function is not have not significantly different from the traditional procedure. And for some special patients, this is a special patient with the esophageal stenosis, so he cannot receive the TEE. We can complete this procedure only with TE guidance, but it's very difficult. It depends on the TE view. If the TE view is not very clear, we cannot do this because it's very dangerous to complete this, this procedure with only TE guidance. And after that, we also invent some robotic. This is the robotic specially designed for TEER procedure. Here are 3 parts of this robotic. The part A and part 2, part 3 is a different part of this robotic. And we use this robotic to complete the world first tele-robotic TEER procedure. The operator, Dr. Pan, is in Beijing, and the patient, one of the patients is in Kunming, and another patient is in Shenzhen. So the patient and the distance between the operator and the patient is more than 2,000 kilometers. So this is, I think this is the first cases of tele procedure in a movement organ. So the next we can now complete the TEER procedure for tricuspid regurgitation with only echo guidance. Sometimes we think that this procedure is easier than the mitral TEER procedure with only echo guidance because the inferior cave is more close to the tricuspid valve, and we do not need the special curve of the first and the second catheter. So it's easier than the TEER procedure for mitral valve and only echo guidance. We always use 2 echo views to complete this procedure. One is the right ventricular inflow and outflow view and biplane view to show the device. And another view, very important view, is the transgastric view to show the short axis view of the tricuspid valve. You see, the transgastric view is very important during this procedure. We should adjust the orientation of the clip according to this view. So the function of this view is similar to the 3D in-phase view when we do the TEER procedure for mitral valve. And we also complete the study with the only echo guidance for TEER procedure for tricuspid regurgitation. So I think the result is very good. We can see that after 6 months of the procedure, almost 90%, more than 90% of the patient had only mild tricuspid regurgitation, and there are we can also observe that the heart function was improved in most of the patient. And the next, and also the most important progress of echo-guided procedure this year is how to do this, how to do the TAVI procedure with only echo guidance. Why we want to do TAVI procedure with only echo guidance? First is we want to avoid radiation damage for both the patient and the doctor. Another is to avoid the intra-procedure use of contrastal agent to decrease the risk of acute kidney injury. And another thing that we find maybe it's the advantage of the TAVI procedure with echo guidance is that we find it's more easier to insert the guide wire passes through the stenosis aortic valve under echo guidance than under the fluoroscopy or X-ray guidance. But there's challenge. The first challenge is which echo view can replace the three crafts co-plan view, or we always use the cross overlap view. This is very important because we really do know how deep we should insert the stent under the aortic annular under X-ray guidance, but we don't know that at echo guidance. So we need to find how deep is suitable at echo guidance. So this is a step-by-step introduction about the TAVI procedure and only echo guidance. First is the piecing lead insertion. I don't think it's very difficult at echo guidance. We always use a bicaval view or right ventricular inflow and outflow view or front chamber view to complete this step. And then the next step is passing through the aortic arch into the ascending aorta. We need to avoid insert the guide wire or catheter into the branch of the aortic aorta. So we always use the pigtail catheter without guide wire in it to directly insert the pigtail catheter. And then we can see this movement. The catheter has passed through the aortic arc into the ascending aorta. And when we can see this step, always we use the TTE suprasternal view to show this process. And then after this, we need to exchange or the echo to TE echo to show the short axis view at the ascending aorta. And then the next is to insert the guide wire into the left ventricle through the stenosis aortic valve. So after the initial stage, when we just begin to do this procedure, I think it's very difficult because you should change your field from the X-ray guided view to the echo guided view. But we can see that very clearly which crabs you insert your guide wire into, and then you can rotate the catheter to adjust the direction of the catheter, and also the guide wire direction will be changed accordingly. So we can always use the LV long axis view and use the biplane function to show the aortic valve level short axis view to show where is the guide wire. And after the catheter, we pass through the aortic valve. The next step is to insert the super stiff or Landerquist or Safari guide wire into the left ventricle. In the beginning of this procedure, we always use the Safari with circles on its tip into the left ventricle. What is very important in this step that is we must know or see very clear the shape of the circles in the left ventricle in order to avoid the damage to the left ventricle view. It's very important, or it will lead to very bad results of this procedure. The next is the pre-dilation of the stenosis aortic valve. I think this step is not very difficult because when we insert the balloon catheter, it can be seen very clearly the balloon has reached the which part of the position of the balloon catheter. If we cannot see very clearly, we can partially fulfill the balloon to show where is the balloon. And then after we confirm the balloon canister is in the right place of the in the right place, we can complete the dilation and completely fulfill the balloon to perform the pre-dilation. This step will always use the LV low axis view and biplan. The next step is the most important step is how to position the stent and only echo guidance. We all know that when we do this procedure under X-ray, we always use the coplan view or Crafts overlap view, which is the non-coronary Crafts is the lowest part of the annular. So when we use the echo view to show this process, we do not know whether of this part, which will be indicated by this simp. We do not know whether this point is the lowest part of the annular. So we must know the low axis view showed the aortic annular is which part are in the X-ray. So I indicated this annular part at echo guidance from the left ventricle, low axis of left ventricle view, and also in the co-plan view or Crafts overlap view. So we know that when we use the long axis view to show the process of the, or to position the stent of the aortic, the valve, we must know that this part of the annular is not lowest the part of the annular. So we always make 6 or to 8 millimeters position this valve 6 to 8 millimeters below the annular. But it depends on what kinds of valve you used. This 6 to 8 millimeter is suitable for Evolut Pro or Evolut Pro Plus. But if you use other different valve, it's maybe not the suitable. For example, if you use some device from China, when you use the long axis view to show to position the valve position, so if you use the Chinese valve, maybe the distance from the bottom of the valve stent to the aortic valve in the left ventricle low axis view should be 3 to 5 or 1 to 3 millimeters. So it depends on different valve you used. So this is the position of the valve stent process under echo valve guidance. You can see from the first echo view, it's too high. The stent maybe the position of the stent is too high. And then you can adjust the stent position. And we insert, in this case, we insert the valve into more deep position in the left ventricle. And it's very important that you, and I think it's also an advantage of when we use the echo to perform the TAVI procedure, that it's very important that when we release the valve into function position, we can observe the stent and the relationship of the stent and of the annular, aortic annular. We can use the biplan function to examine each of the crafts to show the bottom of the stent relationship between the non-coronary cross annular and left cross annular and right cross annular. So we need to scan each of the crops to make sure that the stent is in the right position. Okay, that's the check the PVL. We already see the short axis view and the biplan to show the long axis view. Yeah, this is the completely release of the valve. Here are some cases. This is case 1. This is a type 0 bicuspid aortic valve. And this is the anatomic features of the root of the aortic. So this is a result. Because this is at the beginning of our study, so we always use X-ray to demonstrate whether this the valve position is good. So this is an echo result, and this is fluoroscopy result. Yeah, this is another case. This is a type 1 bicuspid aortic valve. Now we will find a fusion between the left and the right clasp. So this is the echo result. There's no PVL, and I think the position of the valve is good. And also this is the demonstration with the X-ray. So we can think that if you put the valve in position very well, showed by the echo guidance, so it is also in a good position where you use the fluoroscopy. So this is the initial study of 20 patients who received the TAVI procedure with only echo guidance. We achieved 100% successful rate for this for all these 20 cases. So the procedure time, I think, is not very long compared with the TAVI procedure with fluoroscopy guidance. But we must know that there's some limitation for this procedure with only echo guidance. First is that if the patient has the tortuous femoral artery or iliatory artery or abdominal artery, it may be not a suitable case for TAVI procedure only at echo guidance, because we cannot see when the delivery system passes through these vessels. And another thing, we must know that if the patient has high risk for coronary artery obstruction, this patient is also not a suitable case for TAVI procedure with echo guidance. Another thing that we only have experiences with self-expanding valves. We do not use balloon expandable valves to complete this procedure. And the last, I just gave introduction, brief introduction that let us know that we can complete some procedure for arrhythmia using pen procedure. Yeah, this is the, we can implant the pacemaker, dual chamber pacemaker, and leadless pacemaker, and only echo guidance. Now we can also perform the ablation procedure for the atrial fibrillation using only echo guidance. Yeah. This is a new technology, which is the myocardial ablation for the hypertonic cardiomyopathy, now we can complete this procedure by echo guidance. We can insert the guide wire into the septum and only echo guidance through the aorta and the aortic valve into the septum, and then complete the ablation procedure. And we also now can have perform some procedures in the mobile aortic operative vehicle. And I think that Dr. Pan has introduced this vehicle this morning, and I will give not. Actually, I want to show that we have two versions of this vehicle. One is a basic version, another is the plus version. Now we have more than 10 vehicles. This year, these vehicles will drive into different parts of the world, and I think in the next month or sometimes very quickly, one of this vehicle will drive into Uzbekistan, and the plus version of this vehicle will have the space intention function and the luminar flow purification function in the vehicle. So this vehicle is just like a mobile cancer lab or mobile operative room. So we can complete almost all the procedures in the plus version of this vehicle. And now this vehicle has been driven into Laos and different parts of China, almost to the rural area to complete some cases. Okay, that's all. Thank you.
Thank you, Professor Wang. Professor Wang gave us a lecture, I think, full of very professional and advanced ideas. And any questions from audience? Okay, thank you.
Thank you very much, Professor, for a wonderful lecture. I would like to ask you, what do you think about combination, fluoro and echo? In many cases, I think it will be more beneficial for the patient. In one hand, it will reduce fluoro. In other hand, it will to do procedure more quickly and more safer. Your opinion, please.
Okay. When we talk about the complication, when we do some procedures with only echo guidance, first, I think most important is just mentioned by Professor Liu. The first important thing is we must choose suitable cases. It's very important. If we do not, the patient is some challenging case, sometimes we still need a fluoroscopy. For example, the TAVI procedure, if the patient have a large curve in the aorta, so we must need fluoroscopy to guide the delivery system pass through the circle or pass through the challenging part, and then we can use to use the echo view or echo guidance to complete the rest of part of the procedure. But I think most important is the safety of the patient. So we are not to complete some procedures with only echo guidance, but for suitable cases we can do this. But for challenging cases, sometimes we still need fluoroscopy.
Thank you for interesting cases, and just I have one question. You did echo-guided TAVR procedure under the local or general anesthesia?
under general anesthesia.
And that's why I'm asking, this
Because
is also increasing.
Yeah, you need to insert the TEE probe into the patient's esophageal. So must
I think,
receive the general anesthesia.
For such kind of frail adult comorbidity patients, general anesthesia also increase the risk of complications like pneumonia or other complications. And what do you think? Maybe it is safer just to use a short fluoro than general anesthesia and TE.
Yeah, of course. In some centers, I know that this TAVI procedure is completed by the fluoroscopy guidance mainly, but they always use TEE to check whether the position is well or check the PVL. And I do not think that there's a common acknowledgement about whether the anesthesia will increase the risk during the TAVI procedure. In our center, it depends on the patient's condition. If even we use some patients with really low LVEF injection fraction, maybe only no more than 20%, we still will use the general anesthesia, but we will prepare for bypass for this patient. So I don't think general anesthesia will certainly increase the risk of the TAVI procedure. But for some patients, so one thing we want to complete this procedure under only echo guidance. We want to demonstrate it is feasible to complete this procedure under only echo guidance. We are not required all the patients should be done under only echo guidance. So for some challenge cases, also for some cases, it's very weak patient, we still use the fluoroscopy to complete this procedure. Or sometimes we need to use the balloon expandable valve. We also need to use the X-ray to supply the guidance.
Thank you.
Thank you, Professor Wang. I have two questions.
Okay.
One question, important. Who is doing in your clinic PAN procedure, and cardiac surgeon and interventional cardiologist? That's the first question.
Okay.
Who is doing?
Both.
Both.
Yeah, I'm a cardiac surgeon. I perform both the interventional procedure and X-ray and echo view, and I also perform CABG or open heart surgery. Yeah.
Because in another country, I think maybe our country, in the Russian country, maybe another, all colleagues in cardiac interventionals, not a cardiac surgeon. It is very important.
Yeah.
The second question, how many times you observed in crossing by aorta in left ventricle? How many complications you observed? Which virus you use for crossing in aorta in the left ventricle?
Yeah.
It's very difficult type because PANA is not working yet.
Okay. When we insert the wire into the left ventricle through the valve, aortic valve, and the X-ray guidance, we always use a wire named the Road Runner. It's from Cook. Yeah, this is a very more stiffer wire, just than the. I do not know how to see that wire, but it's the name of the wire is Road Runner from Cook. When we use the X-ray to complete this step, we use the Cordis wire. with that's the 150 centimeters Scottish wire to complete this procedure. Yeah, but we do not. I think during our we do not observe some complications of this stamp. We do not happen. Yeah.
Thank you.
Okay. I don't know how long will the patient stay in hospital, in your hospital. But in our hospital, the patient only have 3 days in hospital. So the patient should receive the CT scan before the surgery, before the operation. And during the operation, we need still use the contrast agent to complete the TAVI procedure. And we observed some very old patients. When we complete the whole process, whole treatment process in only 3 days or 2 days, there will be a high risk for acute kidney injury. In fact, in the previous study, we can find the data. Almost more than 16% of the patients who underwent TAVR procedure will have the AKI during the perioperative days. So I think what we want to do to use the X-ray to guide TAVI procedure is to lower the risk of the TAVI procedure, lower the risk of the AKI during the TAVI. So another thing is that many old patients, maybe he has the cancer in pulmonary or in lung or in kidney or in other organs. So maybe they are not very safe to use the X-ray to complete this procedure. So of course, I said, we are just demonstrate that we can complete this procedure use echo guidance. We are not requiring all the patients should be done by echo guidance. Okay.
Because why I'm asking, before the procedure, we're usually doing CT scan,
yeah,
which is, extremely much higher X-ray radiation rather than regular
yes,
cath
because
lab X-ray.
the CT scan, nowadays the CT scan cannot be replaced by other imaging. Do you agree with that? So we use echo cannot give a very detailed evaluation about the anatomy of the aortic root or aortic valve. So the CT scan cannot be replaced by any of other imaging tool. So we can only to decrease the risk of AKI or other complications by avoiding or decrease the radiation or contrast agent during the operation or intra-procedural, because we cannot to find any of the imaging tool to replace the CT scan. But because the CT scan only CT scan can afford very accurate evaluation about the anatomy of the aortic valve.
I think it will be much better to use TE beside the CT scan as a pre-screening TAVR procedure.
But the TE scan, maybe there's some limitation for TE scan. We have tried that. It's not, the evaluation result has some different between the TE result and the CT scan result.
Yes, we have some data. We compare CT scan and TEER and as a pre-screening tower procedure, and it is correlated, T with CT scan. Okay, thank you.
Okay.
Okay, thank you, Dr. Wang, and thank you for your so many fantastic work. Thank you, yeah.
Thank you.
Okay, next speaker is Dr. Meng Hong from Fuwai Hospital, Chinese Academy of Medical Science. The topic is echo-guided percutaneous device closure of ventricular septal defect. Okay, welcome, Dr. Meng.
Respected expert, good afternoon. It's my honor to discuss, to have the opportunity to discuss echo-guided percutaneous balloon mitral valvuloplasty. Echo-guided PBMV is now emerged as a safe and effective option for eligible patients. Before procedure, echo should assess the valvular structure and the subvalvular apparatus morphology. Based on the operation echo results to define mitral valve lesion severity, and during the procedure, echo to provide real-time guidance and monitoring complications. Rheumatic mitral stenosis remain most frequently mitral valve complication of rheumatic fevers. The anatomic lesion conclude commissural fusion. Like this commissural fusion is main mechanism, caudate fusion and Sultan, difficult seeking and in calcification. Based on the echo guideline, we classified the mitral stenosis severity into mild, moderate, and severe degree. We based on the mitral valve areas traced in 2D salt axis view and measured by the pressure half time and trace the mean pressure gradient. Also, we calculate pulmonary arterial systolic pressure to define the mitral stenosis. Based on the recently ESC guidelines, the management of systemic severe mitral stenosis, the treatment option include percutaneous balloon mitral valvuloplasty and surgery and medicine follow-up. Especially during the pregnancy, rheumatic valvular heart disease compromising 15.6 to 89% of cardiovascular disease in pregnancy. The key predictors of adverse cardiac events include left heart obstructions, include mitral valve stenosis, aortic valve stenosis, and LVOT, gradient more than 30 millimeter mercurial. So it's difficult to treat the systematic severe mitral stenosis in pregnancy. So maybe PBMV maybe is considered if indicated. How to define the suitable patients for the PBMV? We always use Wilkins scores. The key features to define the mitral valve lesions, like mobility, leaflet thickening, and caudate involvement. Caudate involvement including fusion and thickening and calcification. These patients, the leaflet is thickened, but only restricted in the tip of leaflets, and it's maybe give 1 point is okay. No significant calcification. The second patient has very markedly same mitral valve leaflet thickening, and especially the posterior leaflet calcification, and the leaflet is markedly immobilities. So it should be given a 2 or 3 point score. The third patient is markedly difficult thickening and multifocal calcification and very markedly restricted difficult mobility. The fourth patient is very especially posterior thickening and nearly immobility difficult. So this patient is not for the PBM. It's contraindication to PBM. Based on Wilkins score per procedure, we will give the score. If the score less than 8, it's suitable for PBMV. But if the score more than 12 or LA left atrium has thrombus or more than mild mitral regurgitation, severe aorta or tricuspid disease, or the need the CBT, we don't suitable for the PBMV. Now is a case demonstration for the pen procedure, totally echo-guided to the PBMV. Echo procedure, echo is used to assess the mitral valve stenosis based on Wilkins score. Before PBMV areas is 0.87. It's confirmed by gradient and or pulmonary PHT method. During the procedure, a catheter is arranged from the femoral vein into LVC and into the right atrium, and transseptal puncture into the LA. Then balloon catheter is arranged into across the mitral valve orifice. Especially the position should be the center of orifice. It's like the X-ray size. Once the balloon waist is arranged into the position of mitral valve orifice, the center of orifice, the balloon is inflated and deflated to improve the difficult mobility. Echo repeated assess mitral valve opening and whether there's regurgitation. After procedure, we repeated assessed by echo. We measure the mitral areas. Post-operation, the area increased to 1.81 centimeter square, and we can do multiple balloon expansion to improve the difficult mobility. A final assessment is made with echo before the approval of a catheter. This patient is a successful treatment. How to define the treatment excellent? We find first left atrial mean pressure less than 11 millimeter mercury, mean gradient pressure less than 8 millimeter mercury. Mitral areas more than 1.5 centimeter. Mild or no significant mitral regurgitation, no complication. How to define the complication? First, acute mitral regurgitation, residual mitral stenosis, percutaneous infusion, arrhythmia, acute heart failure, residual atrial shunt. So inclusion, echo-guided percutaneous balloon mitral valvuloplasty has become a safe and effective alternative for eligible patients. Second, echo can help to guide transseptal puncture to determine balloon sizing and inflammation position. The procedure can be guided by echo entirely. Echo repeat assessment of difficult movement and pressure gradient and change mitral valve areas and subsequent regurgitation. Thank you.
Thank you. Are there any questions from the audience? Okay, thank you. So far, today we talk about the non-fluoroscopic percutaneous procedures, pump procedures, about experiences in different countries from Turkey, Russia, Turkmenistan, and Kazakhstan. Also, Dr. Pan talk about how these procedures are developed and how they are used. Also, we saw the track. There are 2 tracks which can perform these interventional procedures all around the world, and also they explained that there are 8 more, there will be 10. So as far as I remember, they are trying to make a boat for Indonesia or the different countries who are seaside, but it is moving to with the waves, and they are trying to handle it. So in conclusion, we all understand that radiation is not our friend. It's only the friend of Superman, because Superman get the radiation and he is getting better. It's not us. So we have to protect our kids and ourselves and our cat lab staff. So this starts with reducing the radiation, and then all we can do the procedures with just echo guidance, and nowadays with MRI we can also perform these kind of procedures. This is a new area and it is still developing. Also, we listened that there can be mitral clips and there can be made tricuspid clips, and also aortic valve replacement, which is amazing. Also, new data for me that pacemaker implantation or some kind of ablation can be done, like pulmonary vein isolation and ablations can be done easily. And all of these procedures can be done safely, especially for the selected patients. And also we learned that there are biodegradable materials and which cannot be visualized by fluoroscopy, then they can be closed, just need for echo. And also this technique can be developed by learning it. And then what we need guidelines, and then training, and both collaboration. And I think that Dr. Pan and his team is working on this, and they are accepting all fellows or doctors from all around the world. And also new technologies should be implanted to these pump procedures, like these biodegradable materials and how they use. And that's my points that I gathered from this meeting. And Dr. Liu?
Okay, thank you. Okay, thank you, everybody. This afternoon, we have several fantastic topics, and we hope we can keep in touch with each other, and in the future, we work together to promote the PAM procedure and to go further. And in the future, I think we can have the more fantastic work. Yeah, thank you.